Good evening, everyone. I'd like to call to order the April 22nd CMH Full Board meeting. Please rise for the pledge. Next, we will have Lori read the mission statement.
Macomb County Community Mental Health, guided by the values, strengths, and the informed choices of the people we serve, provides quality services, physical recovery, community participation, and substance use.
Thank you, Lori. Next is adoption of the agenda. I'd like a motion to adopt the agenda with one change. I'd like to move item 7G to the end after closed session. So I will take a motion to approve the agenda with that change.
Support.
Motion from Dana, support from Antoinette. Are there any comments or questions on that change? Okay, hearing and seeing none, all in favor say aye. Aye. All opposed? Agenda is adopted. Next is item 4, hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Come on up to the podium. Give us your name.
Hello, everyone.
Good evening. Go ahead.
Good evening. My name is Kennedy Shannon. I am the owner and CEO of Serenity House Residential Care Services. We are an adult foster care provider with the majority of our homes in our corporate office in Macomb County. I'm coming before the board because I'm kind of frustrated and hitting a brick wall. We have gotten a number of calls from individuals. We currently do not have a contract with Macomb County to provide specialized residential AFC care. We've been looking out for RFP, but one hasn't come. We've gotten calls from a number of families who have exhausted options of homes within the network and have been unsuccessful in finding a placement. And they've called us, and we do have places available. However, we don't have a contract. So I reached out to the CEO and sent emails regarding these family members. These are public guardians, private guardians, family members. And the response I get is, well, there's no active RFP. There's no active RFP. But all the CMHs have another way, if necessary, to bring on a provider. And they can do a single point contract when the network is not sufficient to provide housing for that particular individual. So we've been reaching out to inquire about that, but have kind of fallen on deaf ears and have gotten nowhere. There's a little bad blood between the current team that operates that and myself, but it's on one side. I used to be the attorney for another company, and that company pulled their people out of Macomb, and there was some bad blood as it relates to that. And I would hope that that's not the reason why I'm not getting a response back, but it's the only thing that I could think of. But at any rate, I told the families that I would come here today just to voice our concerns, to advocate for them, because there are a number of providers in the network. However, we deal with highly behavioral individuals, and these individual families are getting a lot of rejections because of the high behaviors of their family. So when I get a response saying, hey, wait for an RFP, we have enough providers in the system. But if a family member's gotten 15 rejections from AFC homes because of the behaviors of their family, and we're willing to say yes, they get excited and say, well, great, I finally found someone. But then we tell them we don't have a contract with Macomb. We have a contract with Oakland County. We have a contract with 12 other CMHs. But we don't have one with Macomb, yet we are based in Macomb. All of our homes are in Macomb. So, I just wanted to inquire about the process of what that would be in order to get a single point for some of these individuals who are hearing no. If they can find a placement in the current network, great. These are people who can't find placements within the current network. And that's kind of why I'm here today, just to inquire about what that process would be, or just to at least put it on your radar that that's happening. And I told the families I would come and advocate, whether it is beneficial or not. I at least came. So I appreciate you taking the time to hear me out, and you guys have a wonderful day. Did you have any questions?
Thank you. We can't ask questions or
Okay.
interact, but we appreciate the
Okay,
feedback
not a
and the
problem.
comments. Thank you
so
very much. Anyone else from the public wishing to speak? Okay, seeing none, we will close first hearing of the public, and we will move on to item 5, which is minutes. I'll take a motion to approve the CMH full board meeting minutes from Wednesday, March 25th, 2026.
So moved. Support.
Motion from Lori, support from Sharita. Comments, changes, questions on the minutes? Seeing none, all in favor say aye. Aye. All opposed? Minutes are adopted. Next is item 6. Take a motion to approve the CMH Board Program and Budget Meeting minutes from Wednesday, April 8th, 2026.
Support.
Motion from Donna, support from Jackie. Comments, questions, changes to those minutes? Seeing none, all in favor say aye. Aye. All opposed? Those minutes are adopted. Now I'll move on to item 7. I'll take a motion to approve items A through, A through F, which were discussed at program and budget.
So moved. Support.
Motion from Dana, support from Antoinette. Were there any further comments or questions on any of these items that didn't get resolved? Okay. Hearing and seeing none, all in favor say aye. Aye. All opposed? Those items are approved. And we'll move on to item 8, which is a receive and file of the compliance report that we received at program and budget. I'll take a motion to receive and file.
Support.
Motion from Antoinette, support from Lori. Probably no questions. Should have had them 2 weeks ago. All in favor say aye. Aye. All opposed? Received and filed. Next, we will move on to item 9. I'll take a motion to pay the bills.
Support.
Motion from Sharita, support from Julia. Comments, questions on the bills? Hearing and seeing none, all in favor say aye. Aye. All opposed? Bills are paid. Ken's going to tell us how much money we have. Go.
So I'll apologize in advance due to the length of my presentation. I have both the monthly financials, but also our 2025 year-end results. I think I was sick for the last full board, so here we are. So I'm going to start with the monthly financials, and then we can get into the year-end work. So page 93 of your packet, we got our revenue and eligibles. I think the only thing to really highlight here, we continue to see a downward trend in eligibles. All the PHP CFOs got together, so there's 10 regions, there's 10 of us, gathered that data for what our eligibles are and compared it to what the actuaries presented at the beginning of the year. We're all seeing somewhere in that 4 to 7% decrease on average, depending on the population you're talking about. So it's a statewide problem. We've presented that back to Milliman and the actuaries at the state, so hopefully we're looking at a mid-year rate adjustment to shore up some of that, but you'll see there's kind of a downward trend in February, and that's likely to continue. I'm going to skip over the next page 94 unless there's specific questions and go right to page 96, where I like to spend my time. You can see here that this is what I call our funding source bucket report. If we look at the first 2 boxes, as always, we're running about a $1.2 million deficit if you add Medicaid and Healthy Michigan together. So that's through February. We're looking at probably around $4 million. I think that at the end of the year, we do have some consideration about DCW minimum wage that we might be bringing forward in the future, which might run that number up a little bit. You can actually see it down at the bottom. Our expected distribution out of our ISF is $2.8 million. That's lower than budget. This is an interim financial. I want everybody to keep that in mind as we work through a number of things, particularly CCBHC direct pay and the impact on that. But we will be pulling out of the ISF this year would be my expectation. It's kind of unusual. We haven't had that in a number of years, but I don't think that's something I reported before. But it might not be as much as we had originally anticipated. If we look at the next 2 shaded boxes, so our CCBHC program, we're running a surplus in that program this year. It's based on our revised PPS1 rates that we submitted in our 2025 cost report, which went up considerably as we, the 3 new CCBHCs were taken out of our numbers, so to speak, so we reported without them, and that was our PPS1 increase there. So that's good news. I'll also highlight that the way this is being reported right now is based on, I'm going to say, available T1040s versus paid T1040s. There's an important distinction there. So we've got under the CCBHC direct pay. We're actually billing the state of Michigan now, and we have to bill third parties first. So there's much more delay than there was in prior years. So there's also much more administrative burden and effort collecting the accounts receivable and so on and so on. So we continue to work these collections, but this number is kind of the gross number of what we think the T1040s are, but not what was paid. So that could, at the end of the year, depending on what the state pays or doesn't pay, could fluctuate. So I wanted the group to be aware of that as we move through the year and work through this process. There's a lot going on with that. It's probably our biggest workload item now in the finance department is working this change and all the related things. It's not just so I'll deviate a little bit. The state has approved us to put anticipated costs into our PPS1 rate, particularly for two things. One is the behavioral health urgent care. We've been running that model for a while, so that might not necessarily apply. But the CCBHC direct pay does certainly impact us, and not only the finance department, but I think almost every department at CMH has been impacted by this negatively. It's driving up cost and administrative burden with no benefit to people. So that being said, we will submit that. I think it's due on Monday. We were given a week to put that together. So everyone's working to put that together, but that should drive up our PPS1 rate as well, assuming that it's approved. So I think the CCBHC financials are looking better than originally anticipated. If we go to page 97, you can see our CCBHC non-Medicaid, we continue to have about 1.7 in expense there, 1.7 million. That's not out of line with prior years and something that we have as part of our CCBHC program. As a reminder for the group, or those who may have just joined us, the non-Medicaid expenses are not reimbursed by the state. We have to find other funding sources for that. They do give us, I think last year it was like $300,000 or something, which is a drop in the bucket compared to the roughly $5 million that we spend. So just a point of clarity there. At the end of the day, if we look at the bottom of page 97, that $3 million is still what we expect to have as a surplus in our local funding. So that's good news. We've got some interest earnings. This also doesn't reflect any of our quality bonus payments that we get. So hopefully this number is on the upside, even with some of the other things we have going on. It's really the Medicaid side of things that's the concern at this point. So that's all I really wanted to cover out of the monthly financials. We got a lot with the year end, so I'm happy to take any questions though about that document.
Donna?
Yeah, I wanted to know, we've had some discussions about our risk reserve
Yep.
on the 7.5%, and I'm seeing that for FY '26, we have 56 million in there. Has there been any movement on discussions with the state on our risk reserve? Is that 56 million before or after what the state thinks we owe them? Or is that like what our 7.5% is? I'm assuming not.
It isn't. So yeah, that number is what we believe the ISF should be based on the ISF analysis that we get. So this is not, if you were to think of it as the state's calculation versus ours, this is the one that we feel is appropriate based on county standards, federal guidance, so on and so forth. So that's what that number represents. We are still, we just got our final ISF analysis, the new one coming up, so that'll be reflected in the next report. I think it did go down slightly, but not in a significant way. And I'll actually touch on fiscal 25's number, which I'm realizing unfortunately wasn't updated in here as the beginning balance when I go over the year-end numbers for 25. Okay. So that's kind of a unique situation there as well.
Okay, thank you.
Thanks, Donna. Any other questions before Ken moves on? Okay, go ahead.
All right, let's buckle up. So Year-end results, I'm going to kind of tackle these in a couple different buckets, kind of very similar to how we went through the monthly financials just now. So I'll start with Medicaid, and this is a high-level summary I was sharing with Sharita and Julia before I actually showed them the FSR template. There's a ton of work that boils down into this, but these are kind of I think the key points for the board to note. We continue to have a fully funded savings in the ISF through fiscal 25. Our savings amount, that's also calculated as 7.5% of revenue, kind of unrelated to the ISF, but that was 24.2 million. That amount is not in any kind of dispute. That's something that we continue to kind of roll it. It's an unearned revenue on our books. We can use it in future years. That one's pretty straightforward. The ISF, we actually ended the year with $60.3 million in the ISF. So the reason for that, you can see in the report that we had, the ISF analysis that we have says 58.9. We have interest earnings, as I mentioned, and we have to allocate some of that to the ISF. When we did that, it actually put the ISF over even what our analysis said. So in 26, we have an extra $1.4 million that's above and beyond even what our ISF analysis says, that even by our interpretation of contract and the law and so on and so forth, we would have to either spend or return. So that's kind of a nuanced thing that happened. The reason for that also as well, the difference between 24's ISF number and 25's ISF number was only $500,000. So we can make up interest really quickly on 50 some odd million to bring us not only up to the 500,000, but another 1.4 over. So that's what the situation is there. And again, I'll update that in the next one. But that's how our ISF ended. So not only are we fully funded, we had a little bit extra in there to use and was reported to the state as such. Even with all of that said, our lapse, so again, I'll highlight for the group, our Medicaid funding is kind of like, if you don't use it or have a savings vehicle that we've gone over, you have to give it back to the state. We refer to that as a lapse. So the lapse last year was $34.8 million that we gave back to the state. So I know that there's been questions before. That's a big number, right? So I'd like to highlight for the group, though, there's a couple things that are playing into the item there. So as we've talked about before, at least up through 25, CCBHC had two components of its rate, the capitated piece and the supplemental piece. Those numbers fluctuated from year to year. So when that capitated piece would go up or down, that impacts our lapse. So in this year, we happen to have it work in that favor where we have more dollars to give back. I'll also remind the board that as a result of the direct pay change in 26, they took over $40 million out of our capitated funding. So if we had spent this, we would be 40 some odd million dollars in the hole, in theory, in 26. So while we fully believe that we're supporting our network with rates and doing all of those things, I think it would also be fiscally responsible to spend all of this, and we would be in a bad spot going into 26. So that's an ever-evolving thing. Like I said, in 26, I don't expect us to have a lapse. I actually expect us to pull money out of our ISF. So there's just some context for the group as we think about that. That's kind of the Medicaid piece. I'm going to stop there in case there's questions before I keep moving on. None? Okay. And I think generally speaking, that's not much of a change from prior years. So that one. GF is, and non-Medicaid is the next one I'm going to cover. I don't think there's anything unusual about this either compared to prior years. We actually were able to, through a lot of the work we're doing operationally, I'm going to call it traditional GF, our GF allocation from the state, we underspent that by almost $2 million, which is a good thing. we can also use that to supplement the CCBHC non-Medicaid deficit that I just mentioned. So when we talk about CCBHC non-Medicaid, our total spend for fiscal 25 was $4.7 million. So that's, again, that tracks pretty well with prior years, what we're seeing in 26. It continues to be a risk area for the CCBHC program, but we also had, I think it was $2.7 million in CCBHC quality money that we can use to offset that. So there's a number of things that are playing into this here, but at the end of the day, our addition to our local fund balance was $11.4 million. So we had a really good year financially. Again, a lot of those bonuses played in. We found out not that long ago that because we hit, I don't know, Helen, do you remember the metric on the PBIP that we hit that allowed us to, it was an SUD related one, was it IEP? We actually got $1.7 million more in our local bonus than we thought we were going to. And
I think it was engagement of SUD within a certain period of time, essentially, right? And we were
Right.
one of the only, one or two, to be fair, in the entire state that met that particular metric. So it's weighted. Therefore, there's 10. So they pool it and they go, only one or two met it. So I'm going to take that pool of money and I'm going to give it to the people who met it. So it was a good surprise, as in we didn't know
Yes.
others weren't going to meet it, right? Again, so it's 1.1 million extra just due to our performance.
Yep. So that was a nice,
And that was not the only one, just to be clear. That was one of the large. Yeah, there's actually several measures that we did either best of the one or two, like the only one or two made it. There were other ones that we met much higher than others, therefore it was weighted. And I'm probably not doing a great job of doing it, but the end result is due to our performance, it allowed us to have another financial gain to be able to make up the difference for some of the other deficits.
Yeah, unfortunately, some of our other regional friends, they lost money on this and they redistributed it. We didn't have a hand in that. That was
Yeah.
a state reallocation, but we certainly benefited from it. So I think good news financially for fiscal 25. It does set up, we have a lot of challenges on the horizon. As we know, fiscal 26 is already kind of unfolding like that. Two of the big things I see, not to deviate too much from this presentation, but the redetermination and work requirements that we have coming up. There's also a minimum wage adjustment that's happening on 1/1 of 27. The back of napkin work that Richard has done so far to try to calculate what that might cost, that increase on 1/1 it's hundreds of millions of dollars statewide. And again, it's some back of napkin stuff that he's trying to work up. But that's going to be huge. And we have to support our network in that regard. And there's so far you can go, but we're in a good funding spot for some of those things that are coming up. So we'll continue to advocate with the state. The last piece is the CCBHC. As the group is aware, in fiscal 25, 3 new CCBHCs were approved in Macomb County, so we kind of peeled them out of our program. That amounted to about 30,000 PPS 1 days. It's a pretty significant amount of revenue. There's also expense that went with it, but our PPS 1 rate was not adjusted for this change. So our CCBHC Medicaid piece, not to be confused with the non-Medicaid piece that I just talked about, we ran a $4.2 million loss on the Medicaid side. Because of that, you take that revenue out, they're also lower cost days compared to the days that we provide here. So the expense and the revenue didn't match up. So imagine you take $10 million in revenue, $6 million in cost, that kind of thing. That's how you shake out to this loss. The report that we just submitted for the 2025 CCBHC cost report, obviously that's based on our 25 results. So that PPS number went up considerably and should shore up some of this loss in 26, assuming that the state, they call it rebasing, basically setting our PPS 1 rate to what we reported. It's not terribly clear to me if that's, in the past, they've treated different groups differently depending on when they entered the CCBHC program. So that remains to be seen, but we're hoping that they go forward with that. That is the 2025 year-end results. I do have a couple more things, but anything on 2025 as we think about that? Okay.
Go ahead.
All right. The only other thing I wanted to cover, and I'm glad Sharita and Julia brought it up. Some of you probably received a letter from the auditors, Roslyn Prestige and Company. If you haven't seen it before, that's just a normal thing for auditors to communicate when they're in the planning phase of their audit. So they're required under audit standards to communicate with those charged with governance, the board. What we do as management, what they do as auditors, there's no findings or anything in those reports. Certainly if anyone wants to talk to the auditors, I encourage you to reach out if you have questions, run them through me if you want, or if you're not comfortable with that, they're happy to talk to board members directly for sure. So I just wanted to highlight that, and usually they tell me they're sending that, so I get an email or something out, but in case anybody was wondering about that. So I think that's the last thing I have. If that wasn't enough.
My brain's mush, but I'll get there. Thanks, Ken. Does anybody have any questions for Ken at the moment? Donna? Of course. Go ahead.
So just as a summary, it sounds like, as a summary of everything you said, that we're kind of in better shape than what you originally thought we would be. Is that basically a summary?
For 25?
For 26?
For 26, yeah, the numbers right now, we're pulling less out of the ISF than I thought we might. I will caveat that by saying it's not really related, but it is. The CCBHC direct pay has kind of screwed up all of our data across the entire system. So the reports that are foundational to how we build these are still not really right. So there's we're doing our best basically to cobble things together. It doesn't seem like a week goes by. I met with PCE, who's our EMR vendor, last week to try to work through 4 or 5 bullet points of we're still not there. We moved from an encounter-based system that was pretty clean, and we knew it, to this fee-for-service model, which follows totally different rules. And the programming has been complex, and in defense to our EMR vendor, they were given 3 months to figure this out. And we're still figuring it out 6 months into this idea. So,
You sounded a little more positive than the last time.
well, then I started thinking about CCBHC direct pay, and I went to a dark place. I did.
You sounded a little.
No, yeah, and even within the CCBHC, I think if things, like I said, if we could rebase our PPS1 rate,
Yeah.
get some of these things going. We're working on operational efficiencies, like how can we provide more service that helps people, but also generates more revenue in this model. So we're working all that stuff internally. So I apologize if I was doom and gloom. There's good things going on.
I don't want to put words in your mouth, but it did sound a little more positive
Yes.
than the last report. I heard some positive things.
It is. I do want to, just to that caveat that I mentioned.
Right.
I don't usually have. I probably have a 80% confidence in our data right now. We're still working on a lot, and the non-Medicaid stuff is kind of the worst part of it right now, and also our biggest risk. So that's part of where my head's
The
at.
CCBHCs are unpredictable.
Yes.
We understand. I think we all understand. Thank you.
Absolutely.
Thanks, Donna. Any other questions for Ken?
And I'll just offer too, if anybody has any questions as they go home, and I'm sure you're dying to read this and in front of the TV or whatever, I'm happy to, there's a lot going on, so I'm happy to help with that if there's more questions.
Thank you, Ken.
All right, thank you.
Appreciate it. Now we'll go to Tracy with the CEO update.
Great. So yesterday afternoon or midday-ish, give or take, you should have received the board report. So I am going to kind of highlight some things, but of course the ask is always that you go to that because that has like the details, right? And I really would hope you would click and find out a little bit more about each of the subjects that I'm going to highlight. So if you didn't notice, is from a news perspective, I would definitely encourage you to check out the editorial from the State Association on the Mental Health Framework. There's also some change.org. There's some public entities, as in private providers, that are opposing the current mental health framework proposed by the state of Michigan. So there's a petition that you can see out there. Other things is I shared an article from another state that's trying to revert back to carve-out model versus, and that's how we currently are designed. And then I'm going to talk to you a little bit about, at a high level, some other social media news. Just as a friendly reminder, you have it of this. You have the electronic version also in the board report. But at a high level, I'm just kind of walk through it. And of course, anybody stop me, questions are welcomed. But from a media and social media perspective, the report in front of you is for the last quarter. So let's start with social media. I'm going to look at 3 different areas: engagement, impressions, and growth, right? And then we did some paid advertisement to do some outreach. So when it came to overall engagement in the month of March, it was actually continued to grow for LinkedIn. But then Facebook and Instagram did have lower levels of engagement. You will see as an aggregate for the last quarter, which is what is in front of you, that February was a big month. That was also when we were doing some additional advertising. So there has been a direct link to some of the paid social media advertising that we've been doing and interactions with the public. When it comes to impressions are great. I saw you, right? But what type of interaction? February was again up, same trend, right? And then March was actually, as a general aggregate, less than the previous month. If you didn't already notice it, all of the social media channels that we work all continue to grow with followers. That has been a consistent thing. You will see that Facebook, after doing some of the social media ads, was a little bit faster paced growth. And just, I'm sure you guys already know this, but as a general aggregate also, LinkedIn, obviously the most interactions we have, right, it's more of the professional conversations related to work, that type of thing, where if you notice the Facebook, where we get the most likes, that type of comments, interactions are related to either people who work here, people who work in the community, or, our Mental Health Matters Awards, something that the community directly is involved in. On that, I do want to point out that our highest impressions for the month of March and February were the interviews with Angel Weiss. So if you guys aren't familiar with her, if you see her, please make sure, because as you know, she had a Macomb Daily article, and it was all about her, just to be clear. And then also the videos that she had done on socials, just talking about, her advocacy work and her life story. So if you haven't checked those out, I would highly encourage you to do that. And again, please, if you see her, make sure to express your appreciation for her advocacy. Some articles, I'm just drawing your attention to them. There were 7, but we had Metromon, Macomb Daily, there were 2, CBS News, there were 2 different segments that we were in the last quarter. So that is a very high level overview of the media, both last month, which is in your board report, and here as an aggregate for the quarter. Do you guys have any questions before I move on to the next topic? Okay, great. So the next topic I want to talk to you about is not in your board report, and that is because I just received it today. So we're going to try to continue to enhance member education. We really do want you to know what's occurring in our community and where the needs are gapping and what we can do. That being said, friendly reminder, and I would say to any new people, you guys, if you're not, I'll explain what Happy or Not, but most of you who've been with us for a minute recognize what Happy or Not is. If you physically walk into any one of our locations, or you go to our website as an example, an electronic interaction, it will automatically ask you a generic question like, how was your service today? I don't remember the exact words. It's a question very similar to that, so don't hold me to those exact words. And then it's a quick way to say green face. I'm great, light green face, I'm still happy, but I'm not as happy. And then light pink face, simple as in like I'm unhappy, and then red face, I'm really unhappy, right? It then prompts the person in a couple key areas to give some quick feedback, right? So if I'm a red face, it asks questions. And then there is an ability for somebody to type, imagine on this little screen iPad, any comments that they want. If they do it electronically, because you can use the iPad, you can use a QR code, or you can use a link. If you don't know this, in the bottom of our emails of the clinics, all the staff also ask the same question, and there's a link to encourage people to fill this out. As a general concept, the happy or not is short interaction checkpoints for the people that we serve and the public that we interact with, right? So that is not the only way that we get feedback. That's just our live today. Let's constantly request, how can we help? How can we do better? We do, as a reminder, have an annual consumer satisfaction survey and several other mechanisms, right? This is just the live one. So I'm going to begin to start sharing with you these quarterly ones, because I don't want to inundate you, but I would encourage you to look at this. What's very cool about it, it will tell you how we did overall at each site. It will also tell you what they call pain points. So pain points are if somebody did say light pink face, red face, what are they saying in that when they're doing that? Or the opposite too. It tells you when people are saying what they like, what are the highest things that they're suggesting that they like. So I would encourage you to take a few minutes to check that out. We of course welcome questions. I know I just gave it to you, so I'm happy to answer questions now, but I also, if you have, please follow up if you do have further in-depth questions later. Okay. So continuing to move on, also in your board report, it does draw your attention, and Phil might have other information, but the subcommittee did approve the FY27 budget. It's going to committee as soon as today, I think, or something like that.
The House is voting on them probably right now
Okay.
or tonight, sometime today.
So in that proposed budget, you'll see that I did do a little summary. You do want to draw your attention. I did a summary, and then I also provided the state association summary. I really would encourage you to read it, because there are some things. It did not mention anything specifically about like RFP, no RFP. It did not mention anything specifically about CMHSP, not CMHSP. It does have some autism language in there that we are generally supportive of. And it does still have the $19 an hour for methadone, thank you. I had a blank there. And then it also still has the $66 an hour for autism or ABA. But there are a couple other things that I think, even though Phil would better be able to attest to this, it might not end up being in there, but I think we want to watch this and keep on kind of moving forward with what we're observing.
There's still a long way to go.
There is, but we're watching.
Yes.
Because it's in our best interest to make sure that the right advocacy for the right organizations, populations, that type of thing is relevant. So again, I would encourage you to read through. It is a really good summary. It's about a page and a half, right? So it's a good way for you to quickly get an idea. You'll see that I also am participating our system of care, although it has a ton of challenges that you guys are all aware of. We are constantly looking at how can we better do this better, collaborate, enhance the system of care. I'm participated in a small group of PHP CEOs and CMHSP CEOs and a few providers. And the conversations are about what needs to be different, how can it be different, and then we had some recommendations. Those recommendations today were taken to a larger group, which is not the whole. That larger group gave feedback and as a general aggregate had a few comments here or there, but were supportive. It then is now then it will also go publicly to the full state association. They will all give feedback, but it's again, how do we change the system to improve outside of the challenges and outside entities doing that, because we want it to be the best it can be. They are at a very, very high level, though, just to be clear. So the reason why they're at a very high level, you're trying to get a consensus of the entire state of Michigan. So, and you can read a little bit more about it in my report. Just as a heads up, this is not important my board report, but we are currently, there's two things you'll be seeing soon, either next month or the month after. One is a contract for an outside organization to do secondary reviews of all OT, PT, and speech. So if you're not familiar with NCQA is we're currently pursuing becoming an NCQA certified. As part of that certification, and because it's the right thing to do, we are required for any service that is denied or reduced or partially denied, that you have to have a DO or a doctor, right? Or an MD, medical doctor, or doctor of osteopathy. I think I got that right? Yeah. Review that, even if another master level clinician reviewed it. So we are pursuing a secondary, and that's a third party, we're pursuing a secondary organization to review OT, PT, and speech. And the reason why is Your average physician, right? They are the ones who give a prescription for OT, PT, and speech, right? That makes sense, everybody. They have to be the one that gives that prescription. But sometimes it's helpful to have like an OT professional, right? Or a speech pathologist or whoever it is to give their perspective on a case and kind of give a consultation. So once we execute that, if there is a denial, a reduction of services of OT, PT, or speech, we will still have to have the doctor, DOND review it, but we'll also work with this collaborating organization to have this outside objective review for OT, PT, and speech. This is an extra expense. It's not huge, but we're doing it because we really are trying to finesse kind of those ancillary, or we call ancillary services that you really do have to have a specialty in. So I guess I'm just giving you a heads up that you'll see that because it is a topic of conversation also in the community. So other thing is you're going to be getting Thomas and Libby are going to do a presentation with you in the next month or two on an AI solution that will be a layer on top of our EMR to assist our clinicians with being more efficient. It will not be a listening device, right? It will be kind of taking information, and Thomas, of course, is going to do a much better job than me. But I'm just giving you a heads up that they're going to present it. They really have done a ton of time and a ton of research, and Macomb is moving much slower with AI in comparison to others purposely, right? So we really are trying to do this very strategically, so we take on the right tools for the right reason, and make sure we implement them in the most effective manner. The ultimate goal of this, or what it will do for us, is three major things. One, it will decrease the administrative time for that person sitting with the person, right? Because now it's helping them get the information. It will create more consistency, and the way that's very cool is the system will actually draw attention to things that maybe aren't done well, or, and I'm simplifying it, or missing something, and draw the supervisor's attention so they can consult with the person of how to do this better. It also gives that same information, like from a quality perspective. Somebody from the outside could do some trending and things like that and identify outliers to show if there are some inconsistencies. So again, Thomas and Libby were going to do a much better job than I just did, but I know it's a very important topic, so I'm just drawing your attention to it now so you can start thinking what questions you might have moving forward. So in the board education, I feel like I'm overdoing it today, but in the board education, I really focused on mental health framework. I really would encourage you to read through the summary and the opposition of that. If I simplified it, what that basically means is it is another mechanism for the state of Michigan to privatize. So they are basically taking three decision models, or three different decisions that will take a person served to either go get help from a private health plan or the community mental health services program, or us, right? So one of them is if someone has a score on what they call the locus or the Michicans, so locus is adults, Michicans is child, based on their score, they will either go get help from the private health plan, or they will get help from the public entity, or us. So the problem with using a score is one, a moment in time, right? But they're going to use it unless it changes, and we don't do that assessment. The assessment takes hour and a half, something like that. It's a little bit lengthier, depending on which one you're doing. It also does not take into consideration any SUD, because the locus and Michicans does not address that at all. It also does not take into consideration anyone who's IDD. So anyone who's IDD, both of those assessments would not be applicable for this decision model. So our concern with that one is that we shouldn't use an assessment it should be one of many tools. The second way that they're going to make the decision is out of the utilization. So they're going to look at high utilizers with high needs, and if you're a high utilizer with high needs, you're going to be with us or the PIHP. If you're a low user with low needs, you're going to be with the private health plans. And then the third one is going to be more black and white, which is if you're under a waiver, children's waiver, SED waiver, HAB waiver, you will stay automatically with the PHPs or us. So that's the positive, right? Because it'll stay those for the people that we serve who are used to working with us. The biggest concerns are this assessment model. Also the concern about utilization. It was very, very, what we have is very, very, like 2 paragraphs. It doesn't really say a lot. So one of them would be did they just say that they're gonna give the less expensive, less needs to the health plans? And then the high needs, more expensive to the private, local community organizations? You think that's what they're, of course you can. No, it's projected, no, it's projected October 1st in theory of 26. But I would encourage you, if you notice, I shared some articles, there are some efforts to get it changed. Now, on the opposite side, there is some current efforts from the private health plans to take this new mental health framework and add it into the mental health code as a way for them, because now if it's in the mental health code, now it's law.
How often are you doing the locus currently?
So it would be, and Helen, correct me because I don't want to misspeak, but it would be an initial intake, right? Or annually depending, or if there's a major chain. Like, in other words, if someone goes into the hospital, like something's very different, and in theory, it could be.
Currently, there's a lot of different assessments
Mhm.
on clients.
Well, there's different ones. Those are kind of the main, like the most of the main ones they do. It's just that when you say the word assessment, they also look at social determinants of health. And not to be fair, in the Michigans, it also includes social determinants of health, right? So it's not that black and white. And again, an assessment is not bad. It's just we just want to make sure that people's life circumstances change. And then the other challenge is there's a little bit of frustration or pushback, from my understanding, from the outside providers. So it's not the health plan, but let's say I'm a private provider of the health plan. The amount of money that are given to do that hour and a half work, because you have to go to a full day of training and pass a test to do the Michigans, is very low. Helen, $26? Yeah. So there's a lot of pushback from those private providers saying, no, thank you, health plan, right? Because that doesn't make any sense. I'm not going to do it. I have to send my staff for a day training. They have to pass, and then I'm going to get $26.
Private, and then the locus changes.
Then they're supposed to refer them to I would say this, I'm going to answer the question, and I'm going to tell you to the best of our knowledge today, right? But in that scenario, if they went up or they had a higher need, they would be sent to us or referred to us by the health plan. It could, in theory, go back and forth every month, in theory. I'm not saying that will happen, but we would agree. To be fair, there is this positive motive. The positive motive is trying to make sure the system of care for the people in the state of Michigan is done well. That's the good starting point, and there is a good motive there. I think there's just this lack of thorough plan and thought through, and really they need to engage the people that we serve, because they would tell them what would be helpful and what wouldn't be helpful.
Nick's got a question. Go ahead, Nick.
Yeah. The federal law and our mission statement and the stated position of the state has been to provide for more choice, but the choice was to be with the recipient of services. We're now going to be assigning them based on an evaluation as to what system they have to go into. They don't have any say in that matter?
I think once they go to the health plan, it's my understanding, as you know, there's like 6 health plans in Macomb. So their choice in theory would be, I want this health plan versus that health plan. But
whether I go to a health plan or to a CMH or to a private pay, I don't get to make that choice.
They would not make the choice between a PIHP and a health plan. I don't know a lot of private, that's why I said it that way. I don't want to misspeak.
Yeah, I mean, I think more important, well, you've identified, I think, 2 problem areas, at least from my perspective, 3 actually. The one we just talked about, which is whether that assessment tool is uniquely appropriate, that there are a lot of ways to assess and there are a lot of contingencies to assessment. The second one is one Donna mentioned, which is you could be ending up flip-flopping between different agencies, which means you could be flip-flopping between different providers, which means the continuity of care is going to get shot. And we know, I think, that we've always believed, and there's a lot of evidence, that moving people from one provider to another or from one modality of care to another is disruptive and not in their best interest. And then third is the whole issue of they're not having any choice as to who they want to deal with, uh, whether it's public or private. And, it's one thing to say you're going to give people choice, but then say, but we're going to decide for you what the possible choices are. I think those are serious problems that need to be further explored.
We're currently working on a public comment. It's not full public comment yet, but they will have something soon. So that would also be when we would all want to speak up and share their initial concerns.
My guess is, and Phil will correct me if I'm wrong, but the likelihood of being able to amend the mental health code between now and October 1st is slim, if not none. I mean, to the extent, first off, they don't have, unless they have a bill draft,
There is one, according to someone.
there's an LSB draft.
But when you say draft, my version is it exists. I don't know what an LSB is. Unless you guys do.
Well, you can't, a legislator can't introduce a bill except unless it's been drafted through the Legislative Service Bureau. So the question is, and that's not always an easy thing to get done, because they get backed up, particularly in the budget season, because that's where they have to concentrate their efforts. So the question is there a Legislative Service Bureau draft? And if not, that reduces your chances of taking action even further. Is there a sponsor? Is there anything ready to be introduced? And if there's not, I think their October date is,
There is a
what's the
draft.
word
What I
I'm
mean by
looking
draft-
for?
What I mean by draft is a person is willing to sponsor or willing to submit this, and that they might submit it as soon as next week, is what was advised.
So there is a potential sponsor. Have we seen the draft
No.
legislation?
No.
Okay, thank you.
Okay, so I've killed you with the mental health framework. In other words, I again would encourage you to read it because I did it at a very, very high level, right? I attached kind of an overview. So let's turn to the last and most positive topic. We're very fortunate that we have 228 nominations for the Mental Health Matters Awards. Isn't that amazing? Yes, we're very excited. Of the 228, there's 157 that are unduplicated. Because remember, the same person, which is great, right? Like if somebody really is amazing, you want to hear from multiple people over and over and over again about the good work that they do. If to give you a comparison, last year we had 152 nominations instead of 228. And we also had 119 unduplicated versus 157 unduplicated, just to give you. It was not in your board report, but we did find out just today that CBS News did also do a plug and did like, you should nominate, here's how you nominate, just recently, and we just missed it. So that is one of the theories. We also do a push, and then we do that, like last day thing, and we actually, I want to say, got like 40? Yes, in between, like on the last day. Does that make sense? So, yes, which just was yesterday. The downfall is we might have to relook at the award ceremony a tiny bit different as this gets bigger, because there's only 256 seats. So we'll have to we're gonna work on that, and we're gonna figure out how to make this happen. So yeah. So that is all that is positive. That is a great challenge to have to address. And that is all I have, Phil, unless anybody has any questions.
Any questions? Nope. Okay. Thanks, Tracy. Next is other possible agenda items. We have program and budget here Wednesday, May 13th at 6 o'clock. Full board will be here Wednesday, May 27th at 6 o'clock. And as Tracy mentioned, the awards are Thursday, May 21st. Not here.
Not here.
Not here. Don't show up here. The John Lewis Center, South Campus, Macomb Community College. Do any board members have anything they would like to share before I move on? Okay, move on to item 12, provider comments. I see no providers. Move on to hearing of the public. Round 2.
All right, just simple reminder, health and wellness fair. I did put an example of the flyer on all of your desks. I do have a whole box in my car, so if anybody wants some, but I also have 2 packs, about 25 each, if anybody wants to take them to like the community group, church, anything like that. Anybody? All right.
Thanks, Jeff. Anybody else for hearing of the public? All right, seeing none, we will close hearing of the public, and we will move on to item 14, which is closed session. I need a motion to go into closed session to discuss attorney-client privilege memo dated 4/22/26 pursuant to MCL 15.2681H. Motion from Nick, support from Julia. You all know how this goes. I got to take a roll call vote. Jackie, Donna, Lori, myself, yes. Dana, Antoinette, Sharita, Julia, Nick, Steph. All right. All right, we are back in open session, and we have item 7G that we're revisiting, CCBHC Memo of Understanding. I will take a motion to approve that with appropriate reservation of rights. Motion from Dana, support from Julia. Any comments or questions? Hearing and seeing none, all in favor say aye. Aye. All opposed? Motion passes. Before we leave, Steph, welcome. Congratulations. We're happy that you're here. You're going to learn a lot. If you have questions, please ask any one of us. And with that, I'll take a motion to adjourn. Motion from Dana, support from Sharita. All in favor? Aye. We are adjourned. Thank you, everyone.